Hello, my name is Yasmin. I'll be the student nurse working with you today. How are you?
Good, and you?
I'm good, thank you. So I'm just here to do a cardiovascular assessment, okay?
Okay.
I'm going to start this assessment by asking you some questions.
All right.
So are you aware of any cardiac issues or conditions like heart failure, heart attack, stroke, high blood pressure, cholesterol, or any heart surgery?
No.
No? Okay, that's good. What about any symptoms like chest pain, shortness of breath, palpitations, excessive sweating?
No.
No. All right. So, do you work out?
Yeah, I do.
And then what's your goal when you work out?
Just stay active by getting my heart rate up and sweating.
All right, that's really good to hear. How often do you exercise?
2 times a week.
Okay. Do you smoke?
No.
Drink?
No.
Like any alcohol beverages?
No.
Okay. What about your diet? Tell me a little bit about that. Do you like to eat at home, or do you like to go out a lot, or?
I tend to stay at home, eat a lot of meats, but when I do occasionally go out once a week.
Okay. That's good. Are you taking any meds?
No.
Okay. What about your sleeping? Do you get a good amount of sleep, you would say?
I sleep for the most part.
Around how many hours of sleep?
7 to 8.
7 to 8? Okay. And then when you do sleep, how many pillows do you use?
1.
1 pillow. Okay, good. All right. So, no complications when you're sleeping? You don't suddenly stop breathing, or that wakes you up from that, or anything like that?
No.
Okay. So, because this patient doesn't have any cardiac issues, if the patient were to have any cardiac issues, I would ask about their medications that they take for that. So this could include any blood pressure meds, cholesterol medications, blood thinners like aspirin or diuretics, or a water pill, I would say. But he doesn't have any conditions and doesn't take any meds, so everything looks good there. So now I'm going to start by inspecting the precordium, or the chest. What I'm looking for here is for any abnormal pulsations, locating the PMI, which is on the 5th intercostal space. This is also midclavicular. This is also where the mitral area is, and then also the apex. The base of the heart is going to be located above here, at the level of the 3rd costal cartilage. And then I'm also inspecting for any abnormalities like an enlarged chest, which can be due to perhaps COPD or an uneven elevation of the chest with breathing. We can also see the use of excessive accessory muscles. However, I don't see that here. Everything looks good, nice and symmetrical. So now I'm going to go ahead and palpate the chest. So I'm going to palpate all the areas that we would listen to. And then when I'm palpating, I'm also feeling for any abnormal pulsations again, which can be due to hypertrophy of the heart. And then I'm also feeling for any lifts or heaves. This would cause my hands, or like a rising in my hands with every heartbeat. And then again, this could be caused by an enlargement of the heart. So I did again feel all these areas here, the apex and the base, and then everything feels normal. So the next thing I'm going to do is listen to the auscultatory areas here. I'm going to be listening to the aortic area, located on the right side, in the 2nd intercostal space. And then I'm going to go ahead and go to the left side, second intercostal space, which would be the pulmonic area. Going down one in the third intercostal space would be Erb's point. The left intercostal space. The fourth intercostal space would be the tricuspid area on the left side. And then lastly, the fifth intercostal space, midclavicular, would be the mitral area. This can also be where the apex is, and then also referred to as the PMI, or the point of maximal impulse. When we are listening to the chest, we want to make sure we are listening for S1 and S2, along with any extra heart sounds like S3, S4. And then also for any murmurs or the pericardial friction rub. So S1 is going to be the closure of the mitral and tricuspid valve. And then this usually occurs in diastole, and then this would be the deceleration and contraction of the heart. And it is the lub part of the lub dub. S2 would be the closure of the aortic and pulmonic valve. This is heard at diastole, or with the repolarization and relaxation of the heart. And then this is the dub part of the lub dub. S3 would be the deceleration of blood flow to the left ventricle from the left atria, which occurs early diastole after S2. This would sound something like lub dub E. This can be normal in young adults or athletes. However, it is not normal in older adults, as this can indicate fluid volume overload or left ventricle dysfunction. S4 is heard at the end of diastole, just before S1. And this is an abnormal heart sound, which can be a symptom of heart disease like cardiomyopathy, aortic stenosis, or uncontrolled hypertension. And then a murmur, when we're listening for that, would be a turbulence blood flow, and it is usually graded based on loudness from 1 to 6. And then the pericardial friction rub is going to be caused due to fluid buildup in the pericardial space. And this will sound like two balloons rubbing against each other. And then we can hear this better when the patient leans forward, sits up and leans forward, and we can listen to this in the mitral area as well. If we are having troubles listening to the mitral area, when we go ahead and listen, we can also have the patient lay on their left side. This will bring the heart closer to the chest, which will make it easier to listen to. Okay, so now I'm going to explain stenosis and regurgitation. So stenosis would be the stiffening of the heart valves, which would cause the stiffening of the valves, and then this would cause difficulty or cause the valves not to open completely. And then regurgitation would be weakening of the valves, which would cause a leakage or backflow of blood to the previous chamber that it came from. Now we can go ahead and listen. So when I'm going to listen to these areas we just talked about with the diaphragm and the bell. Okay, so now we're going to listen with the bell using a lighter touch here. All right, so let's see. Okay, lean forward a little bit. Okay. Do that again. Okay, good. So everything sounded normal. So now we can go ahead and lay down. I'm just going to assess the skin, making sure that it is nice, dry, and warm. Any abnormal findings would be cyanosis or bluish tint here, maybe some gray ashen skin tone or color, maybe cool, clammy, sweaty skin. However, everything looks normal here. And then we can also go ahead and check capillary refill. I think this is in the I'll just check it. And then while we're here, we can also have a second nurse to help us assess a pulse for a pulse deficit. So with a second nurse, we can have one listen to the apical pulse and count, while the other palpates and counts. So a pulse deficit would just mean that the apical pulse is higher than the radial pulse, and then this could just be because of issues with the blood flow in the heart. So sometimes AFib can cause a pulse deficit. All right, so that's how we would assess for that. And now we're going to go ahead and do the same assessment with the legs here. So I'm going to feel the skin, making sure it's nice, warm, and dry, which it is. Nice skin tone, normal skin tone here. Again, there's no abnormal skin tone here or discoloration that I see, so everything looks normal. And then when we are assessing the lower extremities, we want to look for any signs and symptoms of arterial and venous insufficiency. With arterial insufficiency, there's a decrease of blood flow in the legs, so we can see cool, pale, thin, shiny skin and no hair, maybe thick nails, and then the patient may complain of numbness and tingling, intermittent claudication, which would just be pain with activity, and then it would be relieved when the activity is stopped. We can also see ulcers that are deep. With venous insufficiency, there's a malfunction in the valves which cause the blood to have difficulties going back to the heart. So then we can see reddish, brownish skin. The skin may be thick and taut. Pulses may be hard to feel, so a Doppler may be necessary. Edema or clubbing may be present, and then the patient may complain of aching and cramping. And then we might also see varicose veins. Compression stockings and elevating the legs might help with this type of insufficiency. The last thing we want to assess is orthostatic hypotension. So with this, we would have the patient lay 5 minutes, take apical and blood pressure, and then have them stand for a minute, take blood pressure and apical pulse, stand for 2 minutes, take the blood pressure and apical pulse, and then a drop of 20 in systole and a drop of 10 in diastole, with an increase of 20 in heart rate would aid in the diagnosis of orthostatic hypotension. Okay, so that completes this cardiovascular assessment.